Hi, I'm Larry Kestin, a radiation oncologist in Michigan. I am the medical director of the Michigan region for Genesis Care, uh, MHP Radiation Oncology Institute here in the Detroit metropolitan area. So in patients with brain metastases, what are the options for radiation therapy and when are they indicated? So the primary options for brain radiation treatment are either whole brain radiation treatment, which is when the entire brain is treated with external beam radiation therapy, usually in 10 to 15 fractions or treatments over 2 to 3 weeks. And then the other primary option besides whole brain radiation treatment would be stereotactic radiosurgery, where one or more individual brain tumors are focally targeted and treated typically with a single high dose RT fraction. Now, there's an additional option, sort of a caveat of whole brain radiation therapy where one can perform hippocampal sparing radiation treatment to avoid the hippocampi. And in studies looking at prophylactic cranial irradiation and in brain metastases, performing hippocampal avoidance with whole brain radiation treatment has improved neurocognitive testing scores and demonstrated less short-term memory loss in patients where that technique is utilized. So that's sort of a third option. But generally speaking, I'm trying to compare, whole brain radiation treatment versus stereotactic radiosurgery in a single fraction. So typically for standard fractionation, whole brain radiation treatment, we would use standard immobilization, such as a mask. But with stereotactic radiosurgery, that can require more complex immobilization methods, such as placing a stereotactic frame with pins into the skull, or a more complex mask system with constant monitoring during the treatment delivery to assure that there is no movement or minimal movement during the treatment delivery. So there are some complex rules to try to decide which is more ideal, radiosurgery or standard fractionation, whole brain radiation treatment. But typically, as a general rule, if there are 3 or fewer small brain metastases, then most would strongly lean towards stereotactic radiosurgery because it generally reduces side effects. The size cutoff for small is not perfectly defined, but is typically around 3 to 4 centimeters or less, depending on the number. Sometimes more than 3 brain metastases are treated with stereotactic radiosurgery. And in that setting, there is no clear cutoff. Some will treat many brain metastases. I think that a reasonable guide to use as a rule of thumb is maybe up to 10 metastases, especially if the combined tumor volume is less than around 35 cc's. So up to 10 with less than 35 cc's total volume is a reasonable rule of thumb. Again, some are willing and may exceed those numbers, and it does depend on a variety of factors. Some other factors that can come into play are radio-resistant histologies, such as melanoma or renal cell carcinoma or sarcoma, which are considered to be slightly more radio-resistant histologies. And in those situations, one might be more likely to choose radiosurgery over whole brain radiation treatment. And also, if the patient has received prior brain radiation, if they've received prior whole brain radiation treatment, then stereotactic radiosurgery would probably be more likely to be recommended. And obviously, I think performance status plays into the discussion. Uh, you know, uh, Patients that are going to undergo radiosurgery, you usually want a reasonable performance status, maybe a Karnofsky of 70 or higher, uh, as a general guideline. Um, and Another caveat is Namenda or memantine, which is a reasonable medication to deliver with a whole brain radiation treatment to try to reduce the likelihood of neurocognitive deficits. Uh, Surgery is performed and a brain metastasis is resected. Uh, Radiosurgery is also commonly performed as an option postoperatively in those patients. Typically, one would recommend brain radiation treatment following surgical resection of a brain metastasis. That can be performed with either whole brain radiation treatment again, or more commonly, I would say now, stereotactic radiosurgery following resection of a solitary brain metastasis.